Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. HIP continued.
We've realigned the camera for a better view of the cross-table lateral, and we've pretty much set the patient up, again, for demonstration purposes. So I'm going to tell you what we've done here. I have a 10 by 12 cassette with a grid set up here. The patient is lying, can you move your leg, Jacqueline? The patient is up on a sponge, okay? You can take a look there. Jacqueline is not heavily built. She does not have a lot of adipose tissue. She's pretty much resting on bone. If we did not build her up with a sponge, this edge of the cassette may clip anatomy. So any smaller patient, it's an excellent idea to build them up at a sponge. And beginning students, I want you to build everybody up until you get to the point where you can judge body habitus. Somebody who's 300 pounds, of course, they're going to have a lot of adipose tissue. The bone won't be resting so close to the table, and you won't need to build them up on a sponge. This patient might be on a stretcher. If they're on a stretcher, just push the cassette down, recognizing that the fact that this edge of the film must go lower, must be more posterior to that patient. I have my tube set almost to a parallel relationship, and this room is awkward to do cross-table laterals. It's a teaching institution, so we don't have the flexible equipment that you will in the hospital. So it's going to be best that you practice in the hospital with the overhead equipment, and you'll actually find in the department that when a trauma hip comes in that certain rooms are selected over other rooms because of the mobility of the equipment. You'll have your favorite rooms to work in. So we're going to get down to some specific details now. Let's focus in on the patient's pelvis. The right leg is of demonstration purposes is the injured leg. We're not going to touch that injured leg at all. But I need to palpate for the ASIS, and I draw that imaginary line again. ASIS, upper border of the pubic bone. That's where I'm going to put the plate of the film needs to be perpendicular to that imaginary line. And this edge of the film goes into the patient's waist, just above the iliac crest. Okay? Iliac crest, push the film in, your imaginary line, and make this angle away from the body until it is perpendicular to that line. Why is that important? This imaginary line is a tool to help you know the shape of the femoral neck. Now that's the imaginary line, and the femoral neck runs perpendicular to that imaginary line. And if the femoral neck is perpendicular to that imaginary line, we want your film parallel to that imaginary line to prevent foreshortening or elongation. We want the tube coming in perpendicular to the femoral neck to give it a true size and a true shape measurement without distortion. So again, film's edge into the patient's waist, 10 by 12 cassette lengthwise. ID blocker is caudal, is towards the patient's feet with a grid, portable grid on there. The cassette is angled away from the body to where it's 90 degrees from that imaginary line. I've tentatively put a right marker on there. Okay, now we're going to focus on the tube for a minute. And the tube setup, I want the tube parallel to the cassette. Beginning students, that might be a difficult thing for you to perceptualize, so here's a trick that you can use. Again, tube, film in a parallel relationship. Use your tape measure. We can focus down on the collimator, and you take one side and measure it to the film. Okay, that measures 31. Go away a ways, and that should measure 31. Then you know that the relationship is parallel. Sometimes it is not possible to get the exact parallel relationship. Sometimes you might have a little tweaking. You shoot for the ideal, knowing that you might not always get it. That is why the film is placed lengthwise with the body, because the grid lines will allow you the flexibility to be not straight, not perpendicular. You'd actually be angling with the grid lines and you will not get grid cut off. So it's very important to have your film lengthwise just in case you cannot maintain that parallel relationship. Okay. You're first learning, and you're still on your recipe card. So we've shown you this with an abdomen series, but I'm just going to try to mock it here. Measure from the tabletop up, and can we see the light? Okay, I can't go underneath the pad and show you, but I've got to go down below the pad, use your tape measure, and the crosshair from the center of your tube should be at the 5.5-inch mark. That will let you know that you're right to the center of the grid. Again, you're measuring from tabletop into the light source, and it should read 5.5. That will put you exactly to the center of the grid this way, because the film is the 10 by 12, but the cassette makes it 11 by 13, and half of 11 is 5.5. You want to check your SID, and you're going to go about 1/3 of the way into the tube housing, and you measure. And this setup, I actually got 40. Many times you cannot get 40. Sometimes you're stuck with having like 44 inches, so you'd have to do your density maintenance formula to compensate for that increase of SID. Okay. Now we need to work on our patient a little bit. You're going to want to get some kind of apparatus, a portable step stool, garbage can, a rolling stool, a chair, and you don't hit the injured leg. The injured leg does not get bumped, does not get moved at all. The unaffected leg needs to be elevated as much as it can. You're trying to get the gluteal fold up and out of the MH. I think the camera can see this. Okay. Now I'm going to turn my light on, collimator light, and I think you can see here, we'll actually move the injured leg just for the purpose of demonstration, okay? You can see the crosshair coming in here, can't you? Okay. That's too low. That's not where the hip is. Here's the ASIS. There's the pubic bone. And you'll recall from the frog leg that you should be about 2 inches below that imaginary line. That's what I'm going to shoot for here. So here's my imaginary line, 2 inches below that. I want that crosshair coming, basically comes right in the gluteal fold there. So I'm actually going to, instead of coming around the camera, I'm going to float the tabletop to fix that. There we go. Okay, now I have the crosshair. See how it's skimming this cheek? Coming right through the hip area, which is 2 inches below that imaginary line. And I'm going to push the cassette into her body a little bit more because I want it exiting to the center of the film. Then you adjust your collimation. And I'm going to have you look at the wall. Let the camera go on the wall there. If it's shooting on the wall, your field is way too big. You need to lower it back down. So if your light is too big, you can look behind it. It will be projected on the wall. You don't want that. You're going to have to come back in, bring it down, and then I have my R marker there, and I think the camera can see that. The ID blocker is right here, so I've moved the L marker or the R marker a little bit more superior because the ID blocker is right here, covered up by the grid. Okay? So let me recap. Uninjured leg never gets moved. The uninjured leg gets elevated, supported on a stool, 10 by 12 with the grid, lengthwise. The edge goes into the waist. The cassette is angled away from the body until it's perpendicular to that imaginary line. You have 40 inches. Again, you might not be able to get 40 because of the tube setup, so you just use the density maintenance formula. You have your tube centered to the grid this way, and the way you did that was the 5.5 inches. And you have the cassette parallel to the tube. I showed you the trick, how you can measure the two sides. You have the crosshair skimming the gluteal fold coming in at a point approximately 2 inches below this imaginary line, exiting to the center of the film. You collimate and you have a marker on there. And that would be your cross table lateral hip with the patient built up on the sponge, unless the patient is fairly hefty in size. How should the image look? If you can't move the leg, the only criteria that you use is anatomy visible. And what anatomy should be visible is the ischial tuberosity, acetabulum, the head, neck, and trochanters, and some of the shaft of the femur. And that concludes the hip.